following episode is brought to you by the American Urological Association. The American Urological Association is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. For more information on how to claim CME credit or to view faculty disclosures, please visit the AUA University at auanet.org/university. This series is supported by independent educational grants from Astellas, AstraZeneca, Janssen Biotech Inc., administered by Janssen Scientific Affairs, LLC, Lantheus Medical Imaging, Merck Co. Inc., Pfizer Inc., and Sanofi Genzyme.
Good evening. My name is Jay Raman, and I'm Professor of Urology at Penn State Health and Chair of the AUA's Office of Education. It's my pleasure to host another one of our podcasts, with this specific episode being part of our Expert Exchange in Genitourinary Cancer series. Today's specific episode is titled Addressing Disparities and Variations in Care in GU Oncology. And it's really my pleasure to host two thought leaders in the field, Dr. Kelvin Moses and Dr. Svetlana Avulova. Dr. Moses is Associate Professor of Urology at the Vanderbilt University School of Medicine, and Dr. Svetlana Avulova is Assistant Professor of Urology at the Albany Medical Center. So first of all, Kelvin, Svetlana, happy holidays, and thank you so much for taking some time to join me on this podcast.
Happy holidays to you all as well. Thank you for having us.
Happy holidays, and thank you for having us.
Perfect. So just to orient our audience, we have several learning objectives in this podcast. And at the end of this activity, participants will be able to, number one, discuss the impact of race and cultural barriers on optimal GU cancer care. Number two, evaluate the financial toxicity as a barrier to optimal patient care in urologic cancers. And number three, incorporate culturally sensitive communications to ensure quality care and reduce biases across diverse patient populations. So maybe I'll start, and I'll open it up to both of you and whomever would like to field this or just kick us off. But just really high level for our audience, maybe talk a little bit about health disparities and racial disparities, and what are these, and how do you sort of think about, or, at least for yourselves, define these terms and these phrases?
Well, I'll go ahead and kick it off. So if you define health disparities, it's really seeing differences in incidence, treatment, and survival of different conditions based on socio-demographic factors. And it would be in ways that you would not necessarily expect based on biology of disease. And so the incidence of breast cancer is going to be very different in women than in men. That's not necessarily a disparity that makes biological sense, but differences in other conditions based on your gender, race, ethnicity, your zip code, especially in a way that's deemed not fair or equitable, would be a health disparity. And the way we see it most glaringly is by race in this country, but certainly also by gender or even sexual orientation.
Yeah, I would agree with what Kelvin said. I think, specific to GU oncology, there's a glaring difference in the diagnosis of bladder cancers between men and women. And this unfortunately leads to downstream effects, like more aggressive disease being diagnosed in women, and therefore more aggressive treatment is needed.
So maybe to both of you, so you sort of help define, both if you look at race or other factors that are not race, what are these disparities? What are some of the causes of this? I mean, Kelvin, you mentioned a few, but I mean, when you think about this topic, are there a certain array of causes that sort of come to your mind as underlying factors for the disparities that we see?
Yeah, I mean, the cause is actually very identifiable, because the cause is a downstream sequela of how the system is set up. So inequitable treatment has been the definition of care in this country since its inception. And so women were viewed as second-class citizens, Blacks were considered non-human, Native Americans were considered subhuman. And so just by definition, we see the ripple effect of 400 years of history in this country. Now, specifically for our time, we see differences because of neighborhood segregation, which still occurs, differences in family wealth, which is a result of different ways that government and banking and education and policing occur in our country. Differences in insurance coverage. Remember, we are one of the few Western countries that practice medicine for profit. And so it's a conglomeration of all these factors that lead to disparate outcomes in various populations.
So give us a little bit of sense. We talked a little bit about bladder cancer and disparities in gender. Well, what else do we see in urology? I mean, just for our listeners, what are some other examples of where there's obvious disparities that we see in clinical practice?
So, yeah, I think that's a great question for clinical disparities in practice. I mean, one example comes to mind is in prostate cancer and the diagnosis of more aggressive prostate cancer in African American men, and therefore potentially leading to more aggressive treatment like radiation or hormone therapy versus offering surgery. Another example would be for small renal masses, and similar example, not offering nephron sparing surgery because of perhaps an elevated creatinine, which was deemed by the race-specific formula for creatinine evaluation.
Yeah, no, I think completely. It's just helpful, I think, as you've illustrated here, to show that, and really to highlight it's not sort of disease specific, right? I mean, even in our small world of urology, it does indeed span across elements of cancer, different types of cancer, benign disease, if you just look at, as you mentioned, sort of calculations of GFR. But I think you summarized really nicely that there are a number of different scenarios. So we've talked a little bit about the fact that disparities exist. We've talked a little bit about some of the causes as well as some of the implications of disparities. So it's always good to think a little bit about, all right, what's being done, and maybe the simple word is solutions, but I don't think we've solved the problem. But what is being done to address these disparities? And I'll turn it over to either of you to sort of tackle that. And I know there's a number of different mechanisms, so however you want to sort of go back and forth to sort of consider the different avenues.
Yeah, I think one of the ways, if you look at it on different levels, right? So you have sort of the governmental federal level approach. You have differential approach between states, and we can talk a little bit more about why certain states make decisions in comparison to others. And then on a more community level based approach. So, on the federal level, when the Affordable Care Act was passed, a lot of the push for that was to sort of equalize treatment or give access to screening and treatment for populations that otherwise were not receiving that. There were also some quality metrics that were associated with reimbursement. And really the whole point too was to move from fee for service to, quality of care and bundling payments. And you see then on a state level, those that participate in affordable care exchanges and particularly the Medicaid exchanges, you saw increases in cancer screening. You saw differences in stage at presentation. More people were getting primary care follow-up, whereas states that did not continue to have poor outcomes. And so states in the Southeast, who have the strongest legacy of slavery and segregation, and some in the West, continue to have these poor outcomes versus states that did participate. On a community level, I think institutions are starting to grapple with their legacies over time. If you look at any medical center that's been around for more than 50 or 60 years, they probably were segregated at some point. And so there's a trust factor with the community. And so institutions, I think, are reaching out more, having community-based engagement, community-based participatory research. There are advocacy groups like Beacon for bladder cancer. And I know Dr. Avulova is very involved with them. The Kidney Cancer Association, Prostate Cancer Foundation, Zero, all these different advocacy groups. They have multiple facets. They do lobbying for research funding. They do educational programs. They do physician engagement things. So there's multiple levels, but certainly there's still a lot of work to do. Maybe Dr. Avulova can speak more on kind of what Beacon does and some things that are going on in the Northeast.
Yeah, absolutely. And I'm glad you brought them up. I think so Beacon is a bladder cancer advocacy network. For those who don't know, it was started by the Qualley family at the time when John Qualley had metastatic bladder cancer. He unfortunately has since passed away, but his wife, Diane Qualley, really has carried the torch in terms of making information on bladder cancer available for patients. And the reason why this organization started is at that time, there were very few resources available for patients diagnosed with bladder cancer. And since being an organization now for almost, I think, 20 years, they've really done tremendous work in increasing awareness. And on one topic in particular is, again, bladder cancer in women. And so, Jay, you asked sort of what are the current strategies? Well, one would be to increase awareness and identify what is one potential reason for, possible factor why women are diagnosed later. Well, are we ignoring the irritative symptoms that they're presenting with? Irritative symptoms or the blood in the urine oftentimes gets dismissed as UTIs or recurrent UTIs. So increased awareness is one through webinars, through educational programs. As Kelvin has said, Beacon has done an amazing job, and as well as increasing research monies for young investigators. And I'm a fortunate beneficiary of such an award, and I feel very grateful to them.
So, you both highlighted very nicely, if you just sort of start with what Kelvin talked about, which is sort of some of the federal and state level, and then Svet, what you talked about, which is, really sort of a commitment for an organization, whether it be Beacon, as you highlighted very, very eloquently right now, KCA for kidney cancer, Prostate Cancer Foundation, whichever it may be. But I think there's sort of different levels that you've all highlighted very nicely. And so we have some of these tools, and we have some mechanisms at various levels. So where are we hitting the hiccups? Where are the barriers? Where are the barriers to progress? And I'll turn it over to either of you. Whether it's federal, state funding, whether it's individual organizations, where are the barriers to progress here?
So the three levels that I mentioned, it's the same, right? There's federal resistance to providing funding for healthcare. There's state resistance to participating in exchanges, which it's a little bit of an insanity to me, because those citizens in the states pay taxes and it's their tax money. And so you're just sort of giving away tax money to cutting off your nose to spite your face. And then it's on an individual level. I think, we as physicians have to understand that we are the advocates for our patients. That is our profession. And sometimes we have to let go of our personal preferences or our personal prejudices in order to advocate for our patients, especially those who cannot necessarily speak for themselves. And I frequently give the example, not that he had personal prejudices, but I give the example of Mark Litwin at UCLA. He went to the California legislature and showed the numbers. Black men die at 2 times the rate from prostate cancer compared to white men. Black and Hispanic men are less likely to get treated for prostate cancer. A lot of it is because of finances. And he got funding from the California state legislature. And so it takes people to kind of step out and provide that care and that advocacy. And the biggest barrier is we don't have representation in medicine that we have in general society. 5% or less of physicians in the U.S. are Black, which has approximately 13-14% representation in the U.S. Similar gap in Hispanic population. And if you look specifically at urology, the numbers are even lower, and certainly for women, right? Like, we're in the resident ranks, those numbers are getting better. Mm-hmm. I would say it's not necessarily representative, but if you look at the population, and again, Svet might know these numbers even better than I do, but we're fighting against battles that has happened historically, but also we're fighting against a group think that says if we just ignore or stop talking about our problems, that somehow it'll go away. And unfortunately, that's not how it works.
Yeah, I mean, I completely agree. I think and I want to provide hope too, as you said, Kelvin. The numbers are getting better, but they're not there yet, especially for women. I mean, I think it's less than 10% of women in urology, even less for women in urologic oncology. But I think the other important factor that we really have to bring this in is for our patients, right? So the lack of diversity in clinical trial development, and most of it is driven by industry, which is helpful, right? This is how we bring in money to find new drugs, and but the lack of diversity in patient representation. I mean, less than 10% of African Americans are represented in clinical trials. So we really need to expand this, and we need help from the NIH to help regulate it. It's a big ask, but unfortunately, we got to keep pushing for that.
So you raise a really good point there, which is, obviously we look at clinical trials and in many regards, certainly prospective clinical trials are the holy grail of what we want to do, right? I mean, they're asking questions, they're investigating, but the conclusions are only as sound as the composition of who is in that group that you're treating. And I think you highlighted really nicely, Svet, that we do have a real issue and challenge with the diversity of persons in clinical trials, whether that's gender, race, age. So maybe just give our listeners a little bit of a sense of, and I don't know if either of you have any of the insight into this. What is being done? What are some of the mechanisms to try to improve the diversity of who is accrued into clinical trials to actually make the findings more generalizable to a population?
Well, so I talked to various industry representatives, MSLs, and they always ask me that same question, like, what can we do better?
Mm-hmm.
And so the example I give them is that Nick Saban is one of the most successful coaches in college football because he goes where the talent is, no matter where. And so for industry and even for NIH, it's very easy to come to Vanderbilt or go to Cleveland Clinic or go to Penn State or go to Albany or whatever cancer center is already in existence because the processes and the resources are already there. But if they don't have a diverse population, then you're missing out. And so you have to go to where the people are. And yeah, you might have to put in a little bit of extra work and a little bit of extra money. And I want to mention that diversity in clinical trials is important. I heard recently someone mention, because and I've made the point many times in my talks that race is a social construct, it's not a biological entity. And so we should not, number one, we shouldn't expect that there should be different outcomes. But the reason that it's important in clinical trials is that because of the environmental effect, because of the likely epigenetic effect of stress caused by racist structures, even if you can't identify them. Sometimes there are differential outcomes. I mean, we've seen in a lot of the advanced prostate cancer trials, Black men have actually responded better to some of the therapies, particularly the ones that are immunologically based. And so that's why they have to be diverse. That's why you need to include these men. But beyond that, if group A dies at twice the rate of a condition compared to group B, and you're trying to close that gap and improve survival overall, who would you focus on?
Mm-hmm.
I mean, if you just take race out of it, then if you want to think of it clinically or objectively, that's why it needs to be diversified, and that's why these companies need to diversify their teams. That's why they need to, when they go to a community and talk about clinical trials, which have such a nasty history in this country, when it comes to Blacks, when it comes to Native Americans, then send somebody who looks like them and can relate to that community. Because again, if there's a history of your company experimenting on people like me at our expense, then I'm not going to trust you until you prove otherwise.
Mm-hmm.
But we still need to participate. So that's where the real change needs to come.
And I just want to highlight another really important disparity, which is, again, I'm bringing it back to bladder cancer in women because this is such a huge gap in literature. Because women get diagnosed less often than men, about 4-to-1 ratio, men get diagnosed more, women undergo less radical cystectomy surgery. And so on a national level, maybe at most high volume centers, at most 20 radical cystectomies are done in females. Clinical data available for surgical outcomes on these women is really limited and disparate rather. And so we don't really have a way to counsel women on what they can expect after this life-altering surgery, because we have single institutional case series to go by, which at most maybe 20 patients a year if they're lucky. And so it's really important not just to, what Kelvin was saying, engage industry, increase diversity, but then also come together as a community and be more open to multi-institutional work where we bring together data, we collaborate, we create these surgical consortiums on rare diseases. So it's really important.
So I think you started to sort of hit on, the area that I was hoping to finish this podcast on, which is, and I feel like it's always good to finish off on, what are the solutions? What's the path forward? And I don't think there's one simple answer to that. But maybe I'll start off and ask you both. I mean, I think there's paths forward, at a you and me level, so individual providers. There's paths forward as an institution. There's paths forward as an organization, whether it be the AUA or advocacy through the that arm of the AUA. So, what are some of the paths forward, and what can people do? So we've outlined really clearly there is a problem. There's a scope of a problem, but what can we do? What can we do from an sort of an actionable point of view? And I'll turn it over to both of you.
So I think one is from an individual level to be open to collaboration, right? And the SUO does a very good job of highlighting need for different trials, different sites, so participating in trials, and then being aware of the different places that need participation, I guess, to be as simple as that, right? But being open to collaboration. I would say second would be to be aware of these different organizations and participate in them, and then also engage your patients and make them aware of these organizations. So let's say, for example, if you do practice in the Southeast and all you see are a certain type of patient population, well, maybe once in a blue moon you see a patient of a different race or a different gender or different background. Well, maybe these organizations will have information on that. And so if you refer your patients to these organizations, then they'll be a little bit more open to talking about it. So even if you may not have certain background or experience, sending them to resources of these different organizations that were already mentioned, they will, like the Prostate Cancer Foundation, for example. They do a really nice job they have a handout on African Americans and prostate cancer. And I give it to my African American patients because they look at me like, first of all, you look like you're 30, and second of all, you're like a young white woman. What do you know about prostate cancer in a Black man? And so I literally give them this handout and I say, read this. And I highlight the points that I want them to take away. And some of those, they may be higher level, education level than they're used to. And so then I'll say, like, what don't you get? Like, let me explain this to you. And if it's not, it's not. And it is salient with them, and they appreciate that.
Yeah, I think that's great. And the point about communication is such a huge thing. We grow up in silos and we grow up in our bubbles. And the more that we can communicate effectively, the more our patients will buy into what we're telling them. And so I appreciate you bringing that up. I think the AUA, again, in general, is starting to recognize that these issues exist by having this podcast and by setting up the Equity Council. but I'll go back to our individual responsibilities. I mean, do we have the political will in order to vote as advocates for our patients? And again, your personal concerns may differ. However, we have a professional responsibility to our patients. We have given an oath to our patients. And so we will, we need to understand that it's one thing to go to a talk or go to a lecture or go to a diversity class. But then if you go and vote in a way or for a particular person or group that is the antithesis of what you say you believe in for your patients, you've almost nullified your argument. So, and that's probably going to be the hardest thing for a lot of people, I'll have to say, especially for as the makeup of our organization or our practice. That's going to be hard. And I appreciate that, but we are the line of defense for our patients, and we have to behave in that way.
That's really well said. Kelvin, Svet, first of all, really enjoyed the conversation, the discussion. Obviously, you both are very eloquent thought leaders in this space. And I first of all want to thank you both for taking some time and sharing some of your thoughts on this podcast for our audience.
Thank you for having us.
Yeah.
And I will say that, it was just a moment ago where I was Dr. Moses's chief resident. So to be called a thought leader, I think is kind of a hyperbole, but I appreciate the comment.
No, I agree with you, Jay. She's the future. It's coming.
I want to thank our audience as well. For more information, please visit us at auanet.org/university. Svet, Kelvin, again, you have a great evening and a happy and safe holiday to both of you and your families.
Thank you very much.
Thank you. Happy holidays.